All so much for being here. The Senate Health, Education, Labor, and Pensions Subcommittee on Primary Health and Retirement Security will come to order. Thank you all for joining us today for the hearing, Avoiding a Cautionary Tale, Policies, Considerations for Artificial Intelligence in Healthcare. And thank you to Ranking Member Marshall for your continued partnership, your staff's continued partnership on the subcommittee. We're hearing more and more about the promise of artificial intelligence in healthcare, the potential for innovation to reduce the red tape facing patients and providers, to identify patterns, improve patient outcomes, and cure disease. But we've heard grand promises from big tech before. In 2012, Mark Zuckerberg compared social media to the printing press and explained that Facebook was built to make the world more open and more connected. But here's the unfortunate truth. Big tech made big promises for innovation, democracy, and community, but instead unleashed big problems on the American people without solutions that were attached by big tech. And our young people have suffered the most. In 2021, 1 in 3 high school girls seriously considered suicide, and at least 1 in 10 high school girls attempted suicide that year, 2021. Among LGBTQ youth, the number was more like 1 in 5 attempted suicide in 2021. And as U.S. Surgeon General Dr. Vivek Murthy concluded in a CDC report earlier this year, there is significant evidence that big tech's predatory practices contributed significantly to this youth mental health crisis. That's why I'm working to pass my bipartisan Children and Teens Online Privacy Protection Act with Senator Cassidy to ensure children and teenagers and their parents have the tools they need when kids are searching and scrolling and connecting online. Fast forward 10 years from when Mark Zuckerberg made his rose-colored promise, and look at our approach to artificial intelligence. And I have concerns, because when we talk about the promises of AI, we need to also talk about its risks. We have learned time and again that left to self-regulate, big tech puts profit over people almost every time. We cannot afford to repeat that mistake by not regulating artificial intelligence now. The risks are too great. Unregulated experimentation involving artificial intelligence may fuel our next pandemic. Humans insert human bias and discrimination into algorithms that can supercharge existing inequalities in our healthcare system, jeopardize our privacy, and misdiagnose or mistreat patients. Big tech's access to sensitive patient information without guardrails exposes people to their most personal information being shared, or even worse, weaponized back against them. Automated review processes will speed up insurance reviews and denials, leaving patients scrambling to get the health coverage they need to avoid choosing between their care and bankruptcy. And amid all of this, health workers are on the front lines of implementing this powerful technology without proof of safety, reliability, effectiveness, or equity. Workers are seeing health systems replace conversations on retaining and paying the workforce with extending and replacing them using artificial intelligence. We don't need big tech treating our healthcare system like a lab to experiment on patients and workers. We need a healthcare system that prioritizes people over heart rhythms, over bots run by algorithms. Artificial intelligence must be paired with a voice for workers in determining their own working conditions, more treatments and cures for all patients, and better access to health care. Otherwise, we are innovating for the sake of profit, and that isn't really innovation at all. It is greed. We can act now to prevent the next cautionary tale. We can pass by legislation, the Artificial Intelligence and Biosecurity Risk Assessment Act with Senator Budd, and the Securing Gene Synthesis Act with Representative Eshoo to require the U.S. Department of Health and Human Services to identify and respond to biosecurity threats involving AI. We can stop corporations from implementing technologies on patients and workers without their knowledge and without appropriate testing to prevent harm, discrimination, or interference with their clinical judgments. We can guarantee that workers and patients have a voice in whether and how artificial intelligence is used. We can guarantee civil rights protection in the utilization of artificial intelligence. We can protect young people from big tech's targeting and tracking and pass a comprehensive privacy bill of rights for teenagers and children in our country. And we have to guarantee that wherever artificial intelligence is used, it prioritizes people over profits. What I've learned in my many years serving on the Telecommunications Committee, I was chairman in the House and I'm the author of all of the bills moving us from analog to digital in America, from narrowband to broadband. Those are all my bills, breaking down all the monopolies. What I learned was the only time you really get things for the little guy is when the big guys want something. So in AI right now, the big guys want something. And we got to make sure we put in all the protections for the little guys in our society. And we got to do it simultaneously, not sequentially, not after the big guys get what they need. That's what this hearing is really all about in the healthcare sector. We welcome everyone, and I turn to recognize Ranking Member Marshall for an opening statement.
Well, thank you, Mr. Chairman, and I certainly appreciate those comments. Artificial intelligence and machine learning have great potential to revolutionize healthcare by developing new cures, improving healthcare delivery, and reducing administrative burdens, as well as overall healthcare spending. And we hope someday very soon, AI and machine learning will allow our clinical workforce to go back to practicing medicine. Those of us in medicine, whether we're a physician, a nurse, a counselor, we all long to spend more face-to-face time with our patients and less on medical records and administrative burden. Other opportunities for AI include developing better standards of care, increasing timely access to care, and perhaps most importantly, discovering innovative treatments, which includes monitoring disease progression and the effectiveness of those treatments. But all that being said, my biggest concern we hope to address today is AI's application in biosecurity and how it could be used to enable bioterrorism. After all, AI can help us prepare or react to the next pandemic, or it could also be used intentionally or unintentionally to develop novel pathogens, viruses, bioweapons, or chemical weapons. As I've always said, those closest to the industry know the challenges, they understand the opportunities and the risk the best. And they also know the most practical and impactful solutions as we look for guardrails that protect Americans, but at the same time, promote innovation. Today, we're asking our witnesses to describe these risks and benefits as best they see them. And if we're to write rules surrounding AI, let's be careful not to destroy innovation or allow those who would harm us to get ahead of us. After all, artificial intelligence and machine learning have been making remarkable discoveries and improving healthcare for some 5 decades without much government interference. I'd like to quote Ranking Member Cassidy, who's done extensive research and written a wonderful white paper on this. Senator Cassidy says, "We must strike the right balance for America, from the earliest stages of developing new products through deployment of an AI system or solution solving complex problems." Mr. Chairman, I have 2 articles here I'd like to submit for the record. First is the white paper from Dr. Cassidy entitled "Exploring Congress Framework for the Future of AI, the Oversight and Legislative Role of Congress over the Integration of AI in Health, Education, and Labor," and also a second document from the American College of Surgeons, a statement to this committee regarding their statement and thoughts on this. Mr. Chairman.
Without objection, so ordered.
Thank you, and I yield back.
Thank you, Ranking Member Marshall. And now I turn to recognize Senator Baldwin, who has a special guest to the committee, who she is going to introduce.
Thank you so much, Chairman Markey and Ranking Member Marshall. I am so proud to welcome a constituent, Christine Huberty, to our subcommittee hearing today. Ms. Huberty currently serves as the lead benefits specialist, supervising attorney at the nonprofit Greater Wisconsin Agency on Aging Resources, and it's located in Madison, Wisconsin. In this role, she provides free legal assistance to northern Wisconsin residents over the age of 60 who need assistance in accessing their benefits, including Medicare, Medicaid, Social Security, and SNAP. She also provides support related to issues with housing and consumer law. As you will hear in her testimony, Ms. Huberty has been fighting on behalf of Wisconsinites who have had critical health services denied by big insurance companies using AI. Ms. Huberty, I want to thank you for your advocacy on behalf of Wisconsin seniors and for making this trip to Washington, D.C. Your testimony highlights the need for us to act to address the use of AI. It is simply not right for patients to have their care dictated by an algorithm. So welcome to the subcommittee, and I look forward to your testimony.
And whenever you are comfortable, Ms. Huberty, you may begin with your opening statement.
Thank you, Mr. Chairman and members of the subcommittee. My name is Christine Huberty, and I've served as an attorney at the Greater Wisconsin Agency on Aging Resources since 2015. As an advocate for senior residents of Wisconsin, part of my job is to provide legal assistance to those age 60 and over who are experiencing health care coverage denials. The purpose of my testimony today is to share how the use of AI in healthcare causes patient harm and administrative burdens. On May 25th of this year, Jim, age 81, was hospitalized for pneumonia, secondary to COVID-19. Jim had a history of COPD and was at the time undergoing chemotherapy for B-cell lymphoma. Jim's doctors recommended that he transfer from the hospital to a skilled nursing facility for short-term rehab. His doctors prescribed at least 30 days of daily therapies in order to return to his prior level of functioning. Jim's insurance provider, however, relied on technology that said he should only need 14.2 to 17.8 days at the rehab facility. Jim received a denial on day 16 with coverage ending 2 days later, just as the algorithm predicted. Jim went home on day 25 not because he was well enough, but because he feared the mounting out-of-pocket costs. Jim's doctors and therapists did not agree with the algorithm's predicted discharge date, nor did they agree with Jim's own decision to return home. AI directed Jim's care. The subcontractors using the algorithm argue that the predicted discharge date is used as a guide only, and medical reviewers, humans, make all final denial decisions. If that's the case, then humans, who had no contact with Jim, ignored the following in his medical records. He was unable to safely swallow by himself and in fact had a choking episode just days after he was admitted. His oxygen saturation remained at unsafe levels. He was at risk of falling and lacked the strength and activity tolerance to participate in chemotherapy. He could not climb the 3 stairs necessary to get into his home. He required assistance of at least 1, if not 2 people with getting in and out of bed, toileting, bathing, and dressing. And most egregiously, they ignored the direct words, "currently not safe to return home with wife." Jim's family helped him appeal twice, which was ultimately successful, meaning the algorithm got it wrong, and a human did not catch the mistake until it was challenged. In Wisconsin alone, our agency has seen the frequencies of these denials multiply from 1 to 2 per year to 1 to 2 per week. In 2023, 30.8 million people were enrolled in Jim's type of insurance nationally. This means that use of an algorithm for this one narrow patient experience is churning out hundreds of thousands of incorrect denials that go largely unchallenged. If Jim had stayed in the facility the full length of time that his doctors advised, it would have cost him over $3,600 due to that denial. Additionally, Jim's health suffered as a result of his early discharge, and members of his family needed to take time off work to provide care. Patients may be reimbursed financially, but they cannot go back in time and get the care that they needed. Insurance companies bank on patients not appealing, or in many cases, with our elderly clients dying in the process. I'm only able to share Jim's story because he had family advocating for him. On his own, Jim may have remained in the facility, drained his assets on care, and been forced to take Medicaid, which shifts costs to the state. If Jim had returned home on his own, most likely he would have been quickly readmitted to the hospital or died. He certainly would not have been able to navigate the appeals process by himself from his hospital bed. Using an algorithm to guide discharges also negatively affects the facilities, who must submit almost daily updates to the subcontractors regarding that predicted date, and provide hundreds of pages of medical records when a patient appeals. Often, nurses and therapists are called to testify at federal hearings. As a result, many facilities are refusing to take patients whose insurance uses this predictive technology due to the administrative burdens it creates. This means that in rural areas, patients need to travel hundreds of miles for the care they need, only to be met with network restrictions when they get there. It is unrealistic to eliminate AI completely from the healthcare system, I understand. However, this algorithm alone has been used for years to direct patient care with devastating consequences. If the machine itself can't be dismantled, then patients should, at a minimum, have a clear view of its moving parts. And when the algorithm gets it wrong, patients need to be compensated, and both the insurance companies and their subcontractors must be penalized. I want to thank you for the opportunity to speak about this important issue, and I welcome any additional questions you have. Thank you.
Yep, thank you very much. Our next witness is Dr. Thomas Inglesby. Dr. Inglesby is a professor at Johns Hopkins University and the director of the Johns Hopkins Center for Health Security. Dr. Inglesby chaired the Centers for Disease Control and Prevention Center for Preparedness and Responses Board of Scientific Counselors. He has advised the Department of Health and Human Services, and he's also served as a senior advisor on the White House COVID-19 Rapid Response Team. Welcome, Dr. Inglesby. Whenever you feel comfortable, please begin.
Thank you. Chairman Markey, Ranking Member Marshall, and distinguished members of the subcommittee, it's my pleasure to appear before you to discuss the use of artificial intelligence in healthcare. My name is Tom Inglesby. I'm director of the Johns Hopkins Center for Health Security and professor in the Department of Environmental Health and Engineering in the Johns Hopkins Bloomberg School of Public Health. I'm also a medical doctor with a background in providing care for patients with HIV. And the opinions expressed here are my own and do not necessarily reflect the views of Johns Hopkins University. AI offers great potential benefits for healthcare and public health. In healthcare, it could drive earlier disease diagnosis. It could reduce medical errors, lead to more efficient, less invasive surgeries. And in public health, it could improve disease surveillance and perhaps provide earlier indicators of outbreaks, even making it possible to contain smaller outbreaks before they become epidemics. However, to realize these benefits, it's vital to address potentially very serious risks. AI developers could inadvertently introduce biases into healthcare-related models. Models could fail to protect privacy, leading to the public sharing of patients' sensitive healthcare data. Training data could include serious inaccuracies, leading to misleading results that are difficult to detect. These are among important risks that Congress will need to assess and, where needed, create legislative remedies. My testimony focuses on two high-consequence risks related to AI and the biological sciences that I believe deserve top priority for attention and strong governance. First, the potential for AI to accelerate or simplify the creation of dangerous viruses that are now extinct, or dangerous viruses that only exist within research laboratories. And second, the potential for AI to enable, accelerate, or simplify the creation of entirely new biological constructs that could start a new pandemic. The executive order on AI signed last week launched a series of important strong actions to address and minimize biosecurity risks posed by AI. In addition, several foundational AI and protein design model developers have already taken important steps to reduce biosecurity risks, which I highly commend, but more action is needed. And to that end, I recommend Congress take 3 immediate steps to further protect against possible high-consequence biological risks emanating from future generation AI models. First, Congress should provide HHS with the authority and resources to require anyone purchasing synthetic nucleic acids in the U.S. to purchase only from a nucleic acid provider that conducts sequence and customer screening, irrespective of funding source. This would build on but go further than the requirements of the executive order that was signed last week, which covered only federally funded entities. And this would help establish uniform protection against the risks of synthesizing highly dangerous viruses in the U.S. and give the U.S. a platform to advocate for strong international screening standards. Second, Congress should commission a rapid risk assessment to identify whether the executive order signed last week will adequately address high-end biological risks or whether additional congressional action is needed to prevent those threats. And I want to commend Chairman Markey and Senator Budd for their leadership on the Artificial Intelligence and Biosecurity Risk Assessment Act and recommend taking this additional step in light of the executive order. And third, Congress should require entities developing products with significant dual-use risks to evaluate and red team their models, identify significant risks, and address them. Congress should also task an agency with auditing these high-risk dual-use models and submitting a report to Congress with recommendations for new authorities that will be needed by the agency to take any appropriate remedial actions. It will be important to conduct red teaming, evaluations, and audits before future dual-use, high-end risk biomodels are made wholly open source on the internet, because once that occurs, they cannot be recalled. We only have one chance to get things right for each new open source model release. If taken now, these measures taken together will reduce the risk of high consequence malicious and accidental events derived from AI that could trigger future pandemics, which would likely also broadly derail the beneficial uses of powerful AI models. Congress should pursue these measures in a manner that will allow AI developers and scientists to continue to vigorously pursue the many very positive uses of AI to improve human health. Thank you again for the opportunity to testify, and I look forward to your questions.
Thank you, Doctor. Our next witness is Dr. Kenneth Mandel. He is the director of the Computational Health Informatics Program at Boston Children's Hospital, and he's a professor of pediatrics and biometric informatics at Harvard Medical School. Dr. Mandel is also, importantly, co-chairing the National Academy of Medicine's Digital Health Action Collaborative, which is working to facilitate the adoption of an AI code of conduct to ensure responsible and equitable use of AI in healthcare and in research. Welcome, Doctor. Whenever you're ready, please begin.
Thank you. Subcommittee Chairman Markey and Ranking Member Marshall and members of the subcommittee.
Could you just move in a little closer or move the microphone a little closer?
Of course. It is with a deep sense of responsibility and privilege that I offer my testimony. As a professor of biomedical informatics and pediatrics and director of a computational health informatics program, I do co-chair the National Academy of Medicine's Digital Health Action Collaborative, but I'm not speaking on behalf of the Academy today. With the release of sophisticated large language models like ChatGPT, AI will transform healthcare delivery sooner than anticipated. These emerging intelligences assimilate vast amounts of information and demonstrate remarkable empathy and profound reasoning. But they are flawed, can produce inaccurate responses, hallucinate, and the precision of their answers changes over time and based on the precise wording of prompts. Consider AI in the doctor's office. The $48 billion high-tech investment in electronic health records digitized medical information, but these systems also introduced complex and distorted clinical workflows, turning MDs into documentation clerks, contributing to physician burnout, and exacerbating the shortage of primary care providers. An early application of clinical AI attempts to alleviate this self-inflicted problem by placing a microphone in the doctor's office and generating clinical visit notes in real time just from the overheard doctor-patient dialogue, allowing doctors to face their patients instead of being turned away and crouched over a computer keyboard. But soon, AI may produce not only the note, but also recommend diagnostics and treatments. Some AI systems may operate independently of physicians, potentially democratizing healthcare access and alleviating physician shortages, but as of now, with no oversight. What if the information is inaccurate? What if a drug company could whisper in the ear of your electronic health record, nudging that AI to favor their pills over a competitor's? We must anticipate and manage a recalibration of responsibilities within healthcare delivery. How will tasks be allocated between human physicians and their AI colleagues? Will AI improve care and outcomes? Even as we speak, patients and doctors are tapping away at keyboards using ChatGPT to navigate healthcare decisions. But here's the catch. There are no guardrails on this road yet. As we reshape healthcare around AI, let's remember that today we don't adequately even measure whether current medical practice is effective. For example, drugs are approved by the FDA with limited data obtained under conditions in a trial. Those conditions are controlled. But how do approved products fare in the wild, in the real world? Do they work like they're supposed to in the messiness of real life? That COVID test you just took, how accurate is it when you're not in a pristine lab, but at your kitchen table? How well did that artificial hip you're about to get work in all the patients who had it before? The National Academy of Medicine's blueprint for a learning healthcare system envisions not just treatment, but learning, and not just from clinical trials, but from the vast ocean of real-world data. Each patient's experience informs the care of the next patient by connecting the dots among every visit, treatment, and outcome. But it's been slow in the making. The urgency of AI should compel us to accelerate a system that meticulously tracks the real-world accuracy, safety, and effectiveness of not just AI, but also drugs, diagnostics, devices, procedures, and models of care. To realize the return on investment on our $48 billion that we've spent, we must demand that the data generated are available to support learning. Thanks to the highly bipartisan 21st Century Cures Act and a rule from the Office of the National Coordinator of Health Information Technology, all EHRs must this year, for the first time, provide a push-button export for their data across what's called an API. Because each hospital or office can produce data in the same format, the care delivery system becomes an interoperable data source in a federated network where the lion's share of data can remain safeguarded at the point of origin. These data can not only drive the development of innovative AI, but also help evaluate AI innovations in real time. Let's learn from another cautionary tale. The HIPAA privacy rule, passed in 2000, guaranteed patients the right to access their electronic health records. But without focused enforcement, nearly 20 years went by before this became possible at health system scale. If the Cures Act APIs are fully supported, we can avoid data monopolies and spark a free market of American innovation in AI while moving us towards a high-performing health system. Thank you for the opportunity to testify. I look forward to answering your questions.
Thank you, Doctor. And our next witness will be introduced by Ranking Member Marshall.
Well, thank you, Mr. Chairman. It's an honor to introduce our next witness here today is Dr. Keith Sell. Now, Dr. Sell is a practicing physician and currently serves as the Vice President and Chief Physician Executive for Ambulatory Services at the home of the #1 ranked basketball program in the nation and a top 25 football program, as well as a top research institute in the country. And of course, that would be the University of Kansas Health System in Kansas City, Kansas. Dr. Sell's clinical interests include sinonasal disease, allergy, and vagus nerve stimulator implantation, though his practice includes the full scope of otolaryngology. When he's not seeing patients, he's leading a partnership with industry to use AI to write clinician notes with physicians put in the electronic health record. Dr. Sell is the president-elect of the American Academy of Otolaryngology Allergy, his National Physician Specialty Trade Association. He's also served as past president of the Kansas City Society of Otolaryngology and Ophthalmology. Thank you for agreeing to testify, Dr. Sell, and welcome.
Thank you for that introduction, Chair Markey, Senator Marshall, committee members. Thank you for the opportunity to be here. It is truly an honor and a privilege. I'd like to focus my testimony on what I think is possibly one of the best impacts that AI can have in healthcare, and that's addressing one of the most serious concerns that faces physicians. That's burnout. Burnout has become an increasing problem amongst our physicians and our medical staff, and it can impact us in ways when it comes to our ability to take care of patients and to manage the amount of patients that come through our doors on a daily basis. When you think about burnout and AI, I want to take you back a little bit to where documentation started, right? So if you go back 20-odd years or so when I started all of this, we were using tape recorders to dictate our notes about clinic visits. And so I'd go in, I'd meet with the patient, I'd have a conversation, I'd walk out of the room, I'd dictate a note. That note would then go to a transcriptionist at the end of the day, who would get that note back to me. I'd review the note and edit it and then put it in the chart. That whole process was a 2 or 3 day process, all right? Fast forward 10 years, we have the EMR, right? So electronic medical record, theoretically the savior of medicine at that time. The challenge was it increased our documentation load because now I am the transcriptionist. I put in all that information personally at the time of the visit. I type in front of the patient and look at my keyboard and my screen instead of talking to the patient, so patient experience is impacted. At the end of the day, half the documentation is now done, but I still have the other half to do. So now I'm adding 2, 3, 4 hours at the end of my clinic day to get my documentation done. Fast forward 10 more years, in the introduction of AI in healthcare and ambient documentation tools. We've now piloted 2 different tools in our organization. The current one allows me as a physician to take a device in the room. It records that conversation. It then takes that conversation and takes the history and the assessment plan and summarizes it based on that conversation, puts it into a place where I can then review it within minutes of that encounter ending. I edit that information, and the editing part is really important because that's how the AI tool learns. It learns what my preferences are, it learns my techniques, my topics, my lingo, if you will, in otolaryngology, and allows that note to be more specific and more specialty specific and patient specific. I then can take that edited note, put it in the EMR, and it's done within minutes of seeing that patient. Now, fast forward to the end of my clinic day, and even though I'd love to say I get all of my notes done as soon as that patient walks out the door, I'm usually behind a little bit, as most of us in clinical practice are. And so at the end of the day, now I have 30 to 45 minutes of time to go through and review notes and plunk them into the EMR. But as I've gotten more facile with this tool, I've been able to get through my notes faster, I have less editing, and the notes are better. There's more detail, there's more information, and the content is more effective for what I need for my future visits, what my colleagues need to see from that visit, and then from what the patient needs, who can also now read those notes. So I think there's a great opportunity for AI technology to assist and remove that burden of documentation and administrative tasks that have become commonplace in healthcare and are truly challenging our physicians and our healthcare workers as we try and keep up with the growing demand of patient care. When you talk about the things that I worry about in AI and how it impacts healthcare, first and foremost was privacy. And so how do we make sure that the tool we're using now, much like the EMR tools we have, adhere to the HIPAA guidelines and criteria we have in place now? I think making sure that anything we build and put in place maintains those privacy standards is paramount. I think as we roll out and develop these tools, AI is a data consumption tool in my mind. I need, as a physician, to have the ability to input and guide what that tool uses and what it consumes to drive the decisions that I hopefully arrive from based on what it produces for me. But it's a tool. It is not something that should replace what I decide in practice or how I make decisions that affect my patients. So ultimately, it is designed to enhance my practice, not replace me in practice. I think there is an issue around data security and as well, and so making sure that as this information passes between different tools, and whether it's my device to the EMR, there are protections in place, again, guided under HIPAA. Lastly, I think what is really unique about the current tool we're using is the traceability and trackability of the information. I can see in real time, as I'm editing my note, where the AI tool achieved its information to create the note that it documented. I can go into that then and understand that why it said cholelithiasis instead of tonsillitis in my note, and I don't even do gallbladder surgery, so it doesn't belong there. I can go in and edit that, and I know exactly where it came from because it's transparent, and I can track it through that AI's workflow. Ultimately, I think there's a great opportunity for AI to help us in healthcare and to make our lives and our workflows better. So I appreciate the time, and you're allowing me to testify today, and I look forward to your questions. Thank you.
Thank you, Doctor, very much. Now we'll turn to questions from the subcommittee senators, and Senator Marshall and I, we're part of a long tradition of partnering between Massachusetts and Kansas, going back to Dr. James Naismith inventing basketball at Springfield College. And then the University of Kansas stealing him away to be
and his
rules to be the first basketball coach at University of Kansas. So this partnership has a long, rich history in medicine and in basketball, and we're good at inventing things, but the application out at the University of Kansas has been much better than any Massachusetts college in the basketball field. And we're hoping here that this partnership that we're creating can help us to get the correct formula, the correct rules, like the Naismith basketball rules for AI. So let me go to you, Ms. Huberty. In your testimony, you included a powerful story of AI directing care for a patient by deciding what is covered by insurance, and that there are many more people who are currently experiencing this who don't know to challenge these decisions that are being made by AI about their health care. Ms. Huberty, what do stories like Jim's that you retold us here tell us about insurance companies and companies developing artificial intelligence and how they're incorporating patient experience versus their profit motivation? Can you talk about the lesson we should learn from that experience?
Sure. I do want to focus first just on the fact that this is not new technology that we're talking about in Jim's case. It's been around since I've started as an attorney. I believe it was used beforehand. So a lot of times when we're talking about ChatGPT, that is new innovations. We're just starting to get a sense of how it's affecting us. But the technology that affected Jim and has affected hundreds of residents in Wisconsin is not anything new. So we have a long history of showing that this algorithm, this use of predictive technology, has shown time and time again that it's incorrect. They come to us in our agency, we appeal, we get it overturned. And so we see that so often that number, that computer, that algorithm gets it wrong, and there wasn't enough human oversight.
Yeah, and who should bear the burden of proving that the use of artificial intelligence won't harm patients? Where should that burden of proof lie?
Right now, I think that should be with those subcontractors that have developed and are using that AI.
Yeah, and I do agree with you, by the way, in terms of this being an old technology. When Al Gore was vice president and I was the chairman of the Telecommunications Committee, when we were breaking down all of the monopolies in the mid-'90s so we could have the digital revolution, the broadband revolution. Not one home had broadband in February of 1996 in America. I used to call these new technologies Al Gore rhythms, right? So it's not a new word. It was obviously what the digital revolution was unfolding at that time, and we had to heed those, those warnings that we were hearing at that point. Bonnie Castillo, who is executive director of the National Nurses United, the nation's largest union of registered nurses, noted in recent written testimony for an AI Insight Forum on workforce that, quote, healthcare workers should not be displaced or de-skilled, as this will inevitably come at the expense of both patients and of workers. And that's true. If not carefully implemented with government oversight and worker input, AI can harm healthcare workers by making them feel like the art and science of healthcare is distilled to typing into an iPad, and that's all there will be to it. Dr. Mandel, your testimony noted how technological advances can contribute to health provider burnout. Can you speak to the danger of using AI in the healthcare settings to automate both tasks and clinical decisions without government oversight and worker autonomy and input?
Well, the worker autonomy.
Can you turn on your microphone, please?
Autonomy and input is very important, and there has to be early on training and education of our workforce so that they can understand what the issues are and understand how to work alongside AI tools, what their functionalities and limitations are. There's a risk today of using an AI tool without understanding its limitations, for example. There are ergonomics and workflow integration issues that are key. We heard today that documentation burden ballooned with electronic health record implementations. We have to design AI tools so that they improve the life and the work life of physicians while maintaining safety. Probably there's mental health support to provide to the workforce as well at a stressful moment when there may be workforce shocks as a result of AI and the shared responsibility between physicians and AI, and we don't know where that's going to equilibrate. There have to be legal and ethical safeguards to protect health workers from liabilities associated with AI. It has to be clear who is responsible if the AI makes a decision that's incorrect. That's going to cause a lot of hesitancy. and anxiety otherwise. We have to monitor, as I was talking, we have to have systems that are monitoring the output of AI and the diagnoses that are made, the treatment recommendations that are made, the claims denials that are made. Those can all be automated with data. We have the opportunity to move forward with getting the data flowing in the healthcare system so that we can monitor safety. And again, it's the same safety that we're talking about for devices, drugs, procedures, and AI. So there can be a float all boats. And then, of course, there are ethics and transparency, and we really need to understand how the AI algorithms were designed, what they're intended to do, and what they actually are doing.
We have to be able to get under the hood, just understand are there biases built in? Is there harm that's inside of this ultimately human-designed algorithm that then takes on a life of its own? What was that human input that ultimately led to the recommendations that were being made? So thank you, and I'll be coming back again. But at this point, I'd like to recognize the senator from Minnesota, Senator Smith, for a round of questions.
Well, thank you very much, Mr. Chair, and thank you, Ranking Member, for deferring. I really appreciate that. And thanks to all of you for your testimony. It's super interesting. There's so many questions I could ask. Dr. Inglesby, I'd like to start with you. Could you talk a bit? We know that AI was important in the way in which we developed the COVID-19 response, vaccine, how we responded to COVID-19, the historic pace of that. Of testing and treatments and developed and vaccines as well. Could you talk about how, what are the lessons learned from that experience, and are there lessons learned as well for not only advancing treatments like the vaccine, but also preventing biosecurity risks, which we're talking about in this committee hearing?
Yeah, well, thanks so much for that question. I think what we have seen with vaccine development, new drug development, and AI tools is that AI can improve the speed and precision and efficiency of many processes involved in vaccine and drug development. They can start with the target and work backwards to decide what will attack that target on that pathogen most efficiently. They can predict toxicity. They can improve the efficiency of laboratory practices. AI tools are kind of across the board, can take on different components of the vaccine and drug development process and make them more powerful. But at the same time, those very processes could conceivably either inadvertently, accidentally, or deliberately be misused to identify things that could harm people on large scale, that could become products that, or biological constructs that could not be controlled. That's my greatest concern, is that we need to set up guardrails, at least to begin with, that are focused on preventing pandemic risks of things spreading in the environment, not being able to be controlled. And I think the companies themselves have said the same things. If you look at what they're saying in the public in the last year, many of the leading companies have said they are concerned about setting up guardrails around biological risks, and that is one of the things that they're explicitly talking about. I think the executive order begins to do that and has many steps moving in that direction. What I would do, though, is I think Congress should seriously consider going a bit further than the executive order, even now, because the role of government still is setting, in the executive order, setting standards, creating a testing process. But in terms of requirements for audits, a government audit of these companies, that's not yet there. And so I think that's the next important step.
You know, one of the things that I have been thinking about a lot is how you overcome sort of the black box phenomenon of these AI models, and how you get accountability around bias, for example. I mean, there's lots of questions around accountability, but how do you think about it as you, from your perspective as a clinician, how do you think about that question of getting accountability in that sort of black box world where we're not exactly sure why or how the model comes up with its answer, let's say?
Yeah, I mean, I think that gets right to the heart of the bias questions that people have been talking about here. And there are many sources of bias. It can be data bias, it can be the model itself and how the model collected the data.
Right.
But one of the strongest things that people talk about in bias is getting rid of the black box, and the term interpretability is really is the key concept around that. And I think that's just another way of saying that in healthcare related AIs that will ultimately drive clinical care, we should be able to look under the hood and understand that process. And right now, with some tools we can and some tools we can't.
Some tools we just have really
And so, but that could be, for healthcare indications of AI, that could become a standard which the government insists upon. We have to be able to see how this, go reverse engineer it, understand how it came up with with the process and recommendations.
Right, right. It's, I mean, that question of how decisions are made and what is programmed into the model, let's call it, you know, gets to the core questions of accountability. Ms. Huberty, I was thinking about your story of the man who was, you know, kind of confronted with this prior authorization recommendation algorithm, which clearly was not being made in his, you know, decisions not being made in his best interests. And I mean, to be clear, I worry about humans in these big insurance companies also not correctly balancing the health risks of an individual with the marginal profit that they may incur by releasing somebody 7 days early or whatever it is. So I know I'm just out of time, Mr. Chair, but could you, like, how do you think about how we kind of get the right balance in these models?
Well, I think in these cases, there are humans involved in running the algorithms and adhering to those discharge dates, but even those humans involved have moral issues with those dates and how they're required to adhere to them within their own company. So I also just think the volume of it too, when you have so many of these denials running through that algorithm, the human oversight is only there when it's challenged. So only when there are appeals do you have that really detailed and careful human oversight where they're looking at the medical records. And so I guess my recommendation is to slow down, to get more of the humans involved, have more of a, the physicians, the treating physicians more involved as well, because the humans involved in those pieces never see the patients. They have no contact with them whatsoever.
Thank you very much. Thank you.
Great. Thank you very much, Senator Smith. And Senator Marshall is willing to forego his turn at this moment so that I can recognize Senator Hassan from New Hampshire for her round.
Thank you very much, and thank you, Senator Marshall. Thank you, Mr. Chair, for this hearing, and thanks to our witnesses for being here. Dr. Inglesby, I wanted to start with a question for you. Artificial intelligence can be helpful when designing new tools to combat the threat of antimicrobial resistance. For example, researchers at the NIH have found that machine learning algorithms can quickly analyze patterns in antimicrobial resistance. This can obviously help public health authorities respond to outbreaks of resistant infections more quickly and efficiently. Artificial intelligence also has the potential to help doctors more precisely diagnose and treat an infection with the right antibiotic at the right dose. So as an expert in health security, can you speak to the role that artificial intelligence plays in our fight against antimicrobial resistance?
Yeah, well, thank you very much for the questions. Very, very important set of issues around AMR. I think there are a number of ways that AI could help in the fight against antimicrobial resistance. And you have mentioned many of the major ways. The first is the design of new therapeutic approaches. We've talked about how new protein design tools, kind of in the category of AI biological design tools, could accelerate the development of new therapies. But also AI can help us with looking at the combination of therapies in ways that were not necessarily obvious through human judgment. So combinations of therapies. They can move from interpreting the sequences of pathogens and making predictions about resistance, and we begin to see that in experimental approaches. We just need kind of a strong data set to be able to move forward on that, but lots of potential.
Well, then, as a follow-up, how can Congress help support the use of AI to better predict and combat AMR?
Yeah, well, I think it depends depending on the category of approaches. I think new therapeutic approaches, I think making sure that BARDA, HHS, and FDA are oriented around new AMR approaches and have the flexibility to make new therapeutics. There are a number of different approaches that BARDA has been pursuing around that. And I think making sure that the data sets that are being developed around these microbes is robust. And I think people talked about the federated approach, making sure that institutions across the country can work together, anonymize data, anonymize patient data, and develop the data sets we need to make those predictions.
Well, thank you for that. I'm going to move now to Dr. Is it Mandel? Dr. Mandel, artificial intelligence has played an integral role in the widespread adoption of electronic health records. Algorithms can help physicians categorize and structure patient data, making it easier for healthcare providers to access and use. While this has the potential to boost productivity and allow providers to spend more time with their patients, we need standards in AI for medical settings in order to ensure that patients are receiving the best possible care and that their privacy is protected. So how can Congress support the development and implementation of these kinds of standards?
Thank you very much for that question. The delivery of AI through electronic health records will clearly be a very important channel for how AI gets to the point of care. For one thing, I think it's very important in that context so that we optimize innovation and excellence to be modular in the way we integrate AI with electronic health records, to make sure that innovators can get to the point of care outside of the electronic health record, but within clinician workflows as well. We want to be sure that the innovation and that the decisions that lead to the kinds of outcomes, good and bad, that you're talking about are not all channeled through a small set of companies, but through the full power of American innovation. I refer to, in my testimony, application programming interfaces. So under the 21st Century Cures Act, there are actually methods to integrate outside technology with electronic health records so that we can move the data to where it needs to be and implement those standards widely. The importance on understanding how AI is working is going to be very heavily placed, I believe, on continuous monitoring. While understanding the algorithms and testing the algorithms is extremely important, until you know how they perform in the real world, you can't fully evaluate them. And these large language models, no one understands. No one understands exactly how they work or exactly how they produce their output. So we're poking the bear and testing. And so there has to be this interactive testing and measuring. And that's how we'll begin to see what emerges. And there has to be collaboration across multiple sectors so that we're all on the same team.
That's very helpful. Thank you. And thank you again to all the witnesses. Thanks, Mr. Chair.
I want to make unanimous consent to enter into the record the November 1st written statement for AI Insight Forum Workforce by Bonnie Castillo, without objections, so ordered. Now I'm going to recognize Senator Hickenlooper from Colorado to chair. Both Senator Marshall and I now have to run over to make the roll call on the floor, and we'll try to run over, make it, and come back. This is, again, how we get our 10,000 steps in. So just turn to Senator Hickenlooper. Thank you.
Great. Thank you, Mr. Chair. Dr. Inglesby, you spoke about the potential for AI models to assist malicious actors in creating highly transmissible pathogens. This is obviously all the more possible given that we do not currently require screening for all gene synthesis providers. Senator Budd and I have a bill called the Gene Synthesis Safety and Security Act, which would help us conduct critical oversight of the industry and protect against misuse of these types of products. If we do not enact federal guardrails here, how would you assess our level of risk?
Senator, first of all, I just want to commend your leadership on that act and think that that is a really crucial step that we need to take to reduce biosecurity risks. I think the executive order goes some distance towards in the direction that your act laid out, but I think Congress could go further in requiring that all of those ordering nucleic acids in the United States abide by the same rule, not just those who are federally funded. But to your point, I think the problem that your act and the executive order has been trying to solve has been the possibility that malicious actors could order nucleic acids from a company in the United States and de novo create viruses that are now extinct, such as smallpox or something along those lines, which we, if released into the public, could create a pandemic. And it's a very clear, the industry is very in favor of regulation in this case, which is obviously quite unusual, but they've been very clear about that. Many of the best actors in the industry are already screening their customers and screening the sequences, but it's not a requirement. So the good actors are at a disadvantage. The bad actors are not paying for that or doing that work. So thank you for your leadership on that.
No, of course, thank you. Dr. Mandel, you wrote in your testimony that, and I quote, "Each patient's experience informs the care of the next patient by connecting the dots among every visit, treatment, and outcome." In many ways, this is the highest ideal of how our health system, under the best circumstances, good circumstances, how it should work. And certainly AI could be a great equalizer in terms of helping us to amass and analyze all and connect all those data points. How can we seize on this moment with AI to catapult our ability to utilize real-world data, but also building the guardrails that you've all been saying are necessary to ensure the security of the data? What is the number one concern you have in mind in terms of the use of AI to manage this level of data, this amount of data, and how should we be working to address it?
Well, I think there's two sides to this. One is the actual use of the AI to look across vast amounts of data that no clinician could integrate in their head, and to do that potentially even in real time in the clinic when a patient is before us. And there we need the guardrails to make sure that the AI is acting in a way that is accurate and beneficial, that's improving the value of care, and there are multiple levels of that kind of measurement. The second place where I think AI can help us is simply by being a burning platform of sorts. If you look at the COVID pandemic, there were some failings, but there were also some incredible successes of the community coming together and moving data to where it needs to be so that we could monitor the pandemic. And as the pandemic went on, we got better and better at it. And the collaboration and the enthusiasm for it was very different than what happened before. I do think that the COVID pandemic receding, hopefully permanently, we see some also receding of that enthusiasm for the kind of collaboration. I think that AI is the burning platform where we can actually try to move the data to where it needs to be to evaluate the healthcare system and to move towards the learning healthcare system, not just for AI, but for drugs, devices, procedures, surgeries, and that there's an incredible opportunity there if we seize the moment.
It'd be an amazing concept to go from spending 18% of our GDP down to maybe 8 or 10% like the rest of the world. That's one way we could move in that direction.
Absolutely.
Thank you. I'm out of time, but I've got other questions that I will submit to both of you in writing. Senator Braun?
Thank you, Mr. Senator Hickenlooper, subbing in for Senator Markey. I ran a business for 37 years that had so little technology in it until I finally, after repeated kind of not wanting to spend the money on it, have been such a believer that if you use it practically, it not only makes things more efficient, it makes things a lot less expensive too. So when I look to see that AI had come onto the scene, to me there are so many practical ways that we can use it to sift through the mundaneness of how you do it without it. And all I can tell you is if you drag your feet on it, you're going to regret it because your competition in the real world is going to use it and you're going to regret it. So, based on that, I wanted to find something that currently is being done by CMS and give it the tools to do it better. So I'm introducing on November 16th and looking for a good Democratic lead. We'll get one, and I think this bill is going to go to town. It's called the Medicare Transaction Fraud Prevention Act. It'll direct CMS to conduct a pilot program of enhanced oversight for two categories of historically high fraud. That would be diagnostic testing and durable medical equipment. By notifying beneficiaries in real time with suspicious purchase alerts, this bill utilizes a successful technique that is already employed by private industry, like our leading credit card companies. It's that simple premise. So I want to ask Dr. Inglesby, what do you think of that idea? We know how much fraud is endemic to so much that government does. I'd like to remind everyone that when we spent nearly $1 trillion on the extended unemployment benefits during the CARES Act, the estimate is anywhere from $100 to $250 billion was stolen by domestic and international fraudsters. And when we're now borrowing $1 trillion every 6 months, and just 5 years ago, it was $1 trillion annually, I think we need to start doing some things that give taxpayers a better value. What do you think of this idea as a bill?
Well, and from what you've described, I haven't heard of this idea before. From what you described, it sounds like a very, very good idea. I'm very in favor of tools we can use to decrease fraud at CMS. I think we use very sophisticated tools in the private sector to detect indicators of fraud or checks. So if those tools can be used in a way that allow healthcare dollars to go to clinical care as opposed to some kind of fraud, I think I would be strongly in favor of that.
Thank you. Ms. Huberty, Hoosiers have been billed up to 20 times for like COVID tests. And this phantom billing of larger durable equipment like powered wheelchairs can involve huge co-payments to boot. What trends do you see in healthcare fraud, and how do you think that impacts seniors financially? And again, do you think a bill like mine would be the place to start, to where you weave it into the system to where it can even address larger stuff down the road?
I mean, everything that you've said absolutely is happening in terms of the billing fraud. There are programs. Wisconsin has a senior Medicare patrol program, and those are available nationwide to do just that, is to address those issues of fraud and detect and report those. So a bill that would be, that would focus in on that extremely. We can, avoid the wasteful spending and those fraudsters. I think to my testimony, though, what I'm getting at is that the AI, those companies are actually committing fraud on the other end, where they are taking Medicare dollars and not putting it back into the pockets of the patients by not offering the coverage that they said they were going to.
Thank you. And one final quick question for Dr. Sale. President Biden's executive order encourages innovation in healthcare services so long as AI models are tested robustly beforehand. The figure that we've talked about is way up there. What do you think? How would this impact a bill like this, taking into consideration what the administration has put out there as a caveat to make sure it's robustly tested? You think this would be a good place to start?
Thank you for the question. I do think robustly testing AI technology is important. I think we've been doing it in our own health system now for the better part of 2 years, trying to figure out how we can make ambient documentation support work and be successful for the rest of our physicians to use and use seamlessly. So I think anything that will allow us to, as clinicians, to make sure that we have input and guidance into new tools that we're deploying with patient care, I think are really important. And then safeguarding how we charge for those resources, I think, is also important.
Thank you very much. And like I say, this bill will be introduced here shortly, and would love for all of you to weigh in on it beyond this kind of brief discussion of it. And I think it's a place to start to where we can build in what I think is going to be, in areas like this, something that's going to completely change the landscape, and it's going to save the government a ton of money. Thank you. I yield back.
Great. Thank you. Now I turn it over to Senator Lujan.
Thank you, Mr. Chairman, and thank you all for being here today. The way I'm looking at this is we need technology to help improve health outcomes, reduce health disparities, not exacerbate them. And it's clear that AI has the power to do both, which points me to the realization that AI is only as good as its inputs. If it's machine learning, it's going to learn based on what exists and what it's done and all the fun stuff that gets put in its way. Well, it seems to me that AI has a diversity problem. And what I want to illustrate here is a recent study from the Journal of the American Medical Association. Researchers reviewed it and said that of the 70 publications that compare the diagnostic decisions of doctors against AI models across several areas of medicine, most of the data used to train those AI algorithms came from just 3 states: California, New York, and Massachusetts. It seems that there's a diversity of data problem by population, by gender, by geography, and all the rest. Now, Dr. Mandel, do you agree that gathering data from homogeneous patient population teaches the AI tool to serve only that population?
I do agree. And the ability to get data not just from the highest performing health systems that are wealthy enough to have teams in their IT departments that can extract data and make it available, but from the edges. We should be able to get data from all of the electronic health records out to the federally qualified health centers. And in order to do that, we need interoperability. And the interoperability should enable us to get data to train algorithms and to monitor algorithms. And there's another area that's a little more hidden where these algorithms are being developed that could limit diversity. And in the large language models, the models are further trained after they're been developed on the data, which already may lack diversity. They're trained with something called reinforcement learning with human feedback, where people tell the AI whether it was right or wrong when answering certain questions. And so we actually need a diversity of staff who are doing the reinforcement learning as well, so that we get the right mix across multiple perspectives. So the issue you bring up is extremely important. It's demonstrated over and again that that lack of diversity in the data leads to biased conclusions that do not serve the full population well.
So as a follow-up, Dr. Mandel, is it important to include this at early stages or later stages? And if the answer is yes, why?
The early stages is much better so that the models are developed with less bias at the beginning. That bias can become entrenched and harder to fix later. And so technically, far better to try to solve the problem early with diverse data and appropriately diverse reinforcement learning staff, and rather than just trying to correct the bias later. Absolutely.
I appreciate that very much. Other examples that I've found with the help of the team are that AI trained mostly on chest x-rays from men will perform poorly when a clinician applies it to a female patient. An algorithm for diagnosing skin cancer on dermatologic photos will botch the diagnosis if the patient is dark-skinned and most of the training images come from fair-skinned. I think these are obvious things that are happening in this space, that technology such as what I'm wearing as well has been proven that when you're trying to capture information from someone where those that were in the room developing that technology may have been one skin color versus another, maybe it was not obvious to those in the room that they should have included pigment awareness and challenges when they were trying to grab this technology. So I'm hopeful that we can be smarter about this and that this can be included so that the same problems that have been identified in the lack of diversity when it comes to clinical trials of drug treatments are not replicated now that AI is on the boom and on the build and all the rest. So I have lots of other questions, Mr. Chairman. I'll submit them into the record, but I thank you very much for this important conversation.
Thank you, Senator Lujan. Senator Marshall?
All right, thank you, Chairman. Again, welcome to all of our witnesses today. I think that the question that I'm going to start with is what should Congress not do right now with AI? What should we not do that would prevent innovation from continuing? What scares you, Dr. Sell?
I think, when you think about innovation in healthcare, we do innovation as part of our practice of medicine, and it's been ingrained in what we do, especially in the academic world where I live, right? And so it's all about how we move forward with patient care and drive and change and make improvements in patient care. And I think my fear would be if we somehow limit or restrain the ability to utilize this type of technology in healthcare. I think, as I mentioned earlier in my testimony, there are a tremendous number of applications where AI is beneficial and can be beneficial in patient management, patient throughput, patient access, physician well-being, et cetera. And so I think if there's any fear that I have, it is that this technology would be actually removed or limited in some way. I think we want to be actively engaged as clinicians in developing that tool. So I think if there was any way that we would be somehow cut out of that process, I think that makes me nervous. But I think those would be the two areas where if there's anything that the government would do that would limit our access to or ability to participate in the development of this tool, I think that would be scary for me.
Thank you. Let's go ahead to Dr. Mandel next.
I'll say that I would avoid actions that would promote unregulatable monopolies, and I would be very cautious when designing specific regulations to recognize the extremely rapid change in this technology. It's not even enough to keep up with the medical literature. You have to be following releases and announcements on Twitter a couple times a day to understand what's going on in this field, not reading your journals once a week or once a month. So it's very important to recognize the fluidity and the rapid progress and to develop evergreen approaches to monitoring this emerging
I hear you saying it's going to be really hard to put. It's going to be hard to put guardrails around it because it's changing so fast. Yeah.
It will be a challenge.
Yeah, Dr. Inglesberg.
Yeah, I think it's a really important question. I think what I would say is Congress should not take their eye off some of the most serious risks, because if those risks become a major problem, either in bias or in what I'm worried about, particularly around life science, pandemic risks, or others, I think those kinds of developments could derail or really distract the AI companies, could distract the government for a long time if major problems emerge. And so back to what you said early in this hearing was, I do think that the AI companies have extraordinary expertise, and it's going to be very important for the government to stay close with them and not be at a distance and not kind of disengage. I think it's going to require very close partnership because a lot of the expertise, the great majority of expertise right now is in the industry and not within the government. I do think the government has to build its workforce of very smart AI talented people to be able to keep up. So I think you're right. Working with industry closely is going to be very important in order to both reap the many benefits, but also to develop systems that are reasonable and scaled to deal with the risks.
Okay. Ms. Huberty, within your association, when you go for continuing education, when people in your profession talk about AI, What concerns have we not talked about today that you have? Or any solutions? Go ahead.
Right. I would like to actually speak to the question that
Oh,
you
good.
had to the doctors, because we have been sitting here talking about what if.
Okay.
I am sitting here telling you that we have seen the negative consequences. We have seen the devastating effect of AI for years. And I was here in May testifying before the Medicare Advantage plan hearing. And so I'm sitting here saying, well, here is harm. Here is proven harm from AI. So what are we going to do about it? My fear is that we're doing nothing. We aren't doing anything. So that's my contribution to that, is that we need to be doing something.
Okay. Dr. Inglesbury, let's talk about viral gain of function just for a second. Viral gain of function research, and certainly AI could be used with this area, and it probably has been, whether you're trying to develop a protein spike that fits on a SARS virus, maybe insert an HIV code from the HIV virus in to decrease people's level of immune reaction, or put a furin cleavage site as well. One thing that scares me, though, is if Congress puts too many guardrails on it, is we let our enemies do research and develop things that we won't be able to counter. Counterterrorism, if you would speak. Any just vague general thoughts on that? It's kind of a wild, outside-the-box question, sorry.
Well, no, I think it's very, very, very important. I think this last year and a half, there's been a lot of work between the government and the scientific community around trying to develop the right policy that focuses only on the very highest risks around potential pandemic pathogen research. I do think that if the U.S. gets its house in order, it can then argue for kind of the similar standards around the world. In this case, I don't think other countries want to be creating new viruses. I don't think governments are going to want to create viruses with pandemic risks that they're not aware of. They're going to want to have the same kind of understanding of what their science communities are doing. So I think ultimately all governments, in theory, should be moving towards the same kind of arrangements, which is not slowing science down, but being aware of that little area, that small area of science, which could pose extraordinary risks, and just doing the right thing, working with industry.
Yeah, doing the right thing is so important, right? You know, we've all seen in healthcare innovation, so many technologies come by our desk. You know, there was a time when people thought, oh my gosh, we shouldn't do MRIs because it could lead to overdiagnosis. And certainly you don't want an obstetrician reading an MRI, but it didn't stop us from developing the MRI technology. As I think about these algorithms, at the end of the day, I think it comes down to people doing the right thing and us teaching our medical students the right thing, that this is one more tool. It's no more important than a CBC or an X-ray, and it's no more important than a stethoscope. Do you remember that fourth year of medical school when you suddenly realized the most important tool you had in the toolbox was listening to a patient? If you could only have one thing, it'd be listening to the patient. And I just would implore you all to keep the patient first. And as we teach our medical students that this is a tool. You know, like I tell people, I've seen one pregnant person with a virus, you've seen one pregnant person with this virus. The next pregnant patient may not obey the algorithm. There are more than 2 standard deviations outside the box. That's all algorithms are for the most part. Here's 2 standard deviations. Most people should be in the hospital 2.3 days after being admitted with pneumonia, unless they develop a blood clot. So it's going to come up to the person, people doing the right thing in our professions to protect. I would love to come back and talk, what are your professions doing to protect the integrity of healthcare? But I do appreciate you all coming in. It's been great insight. Thank you.
Yeah, I'm going to ask a few more questions, if that's all right, Senator Marshall. Thank you. Back in the 90s, when there'd be a headline, like once a week, insurance companies' records hacked, made public, or hospital records hacked, made public, or you name it, hacked, made public. And so I asked Joe Tucci, who was the CEO of EMC up in Massachusetts, which was the leading data storage company in the world, Dell has now purchased it. And I said, what's going on? He says, oh, we could have protected all those companies. We try to sell them our highest end security product, but they just don't want to buy it because it costs them too much money. So they'd rather run the risk of having the data breach. And so I said, so the technology is there. The counter algorithm is there to fight against, what becomes the state of the art in terms of the criminals trying to break in. Oh, yeah, it's there, but many companies or the executives just don't want to spend that extra money. They're hoping they retire before their company gets hacked so they don't have to explain to the board of directors why they had to spend all that extra money. So it was a big insight to me that, there's a battle that's going on, good versus evil, but good's in the battle too. It's just, are we going to have it deployed? Are we going to ask that be just maybe a little extra cost that has to get built into the system to protect against the deleterious aspects of any new technology? It's that challenge, right? Because profits would say, no. Look at how much we max out if we just deploy this new technology without the additional safeguards, which could be built in. I introduced with Senator Budd, Republican on this committee, the Artificial Intelligence and Biosecurity Risk Assessment Act and the Strategy for Public Health Preparedness and Response to Artificial Intelligence Threats Act to direct the U.S. Department of Health and Human Services to prepare for AI biosecurity threats. In your testimony, you noted that President Biden's executive order is an essential step forward for AI oversight, but that there's more to be done. So, Dr. Inglesby, could you just tell us how important it is for Congress to play a role in regulating AI now?
Yeah, I'm happy to do that, and I think your act really spoke to the importance of that. I think the executive order goes a long way in assigning responsibilities to NIST, Department of Energy, Commerce, HHS, but it doesn't require much yet of the companies. I think they're trying to understand the nature of the problem. But I think what your act proposed and what I would also recommend is that you get an assessment from HHS, I think is the most logical place. HHS ASPR, I think, would have the right expertise to give you a stronger sense of what are the risks of the creation, AI helping to simplify or accelerate the creation of new, very serious biological risks, and what could be done, what authorities, if any, are needed to be able to deal with that. I think some are in sight now, which are, I think Congress should be giving audit authority to an agency, whether it's Commerce or Energy or HHS, around AI risks. But I think such a risk assessment that's done rapidly, aimed at congressional leadership, which is a little bit different from what's now in the executive order, I think would be very valuable for leadership here to decide what they might want to do.
Yeah, and again, that's the goal that Senator Budd and I have, just kind of moving this ball further down the line. And we see it in all kinds of areas, in the automotive sector, the automotive industry, they wanted to sell you a new car, but they didn't want to have a mandatory seatbelt that was built in. That'll be an extra cost. Not every consumer wants seatbelts. I know my father, the truck driver, he really didn't like seatbelts, so they were saying consumer choice. And then airbags. Well, not every consumer wants an airbag. Yeah, but it's a safety feature. Yeah, but, we'll leave it up to the consumers to do it. So the industries that trying to downsize their safety cost requirements until the consumers get a little bit of a taste of an airbag and a seatbelt, and then they're saying, I'm not going to buy a car that doesn't have safety built in, right from the get-go. And so we continue to have this conversation that coexists with the technological advance, but then as people catch up, they're going, well, could we have a little more, could we have a child safety cap on top of that medicine? Is that too much of a cost, to please ask you to build that in, and so there's going to be some resistance, but you're just trying to balance it. You don't want to take away the good part of it, but you know that there's a sinister side to cyberspace. So can I just come back to you, Dr. Sale, and I just heard that conversation that Senator Marshall was having about fourth year of medical school, which I'll never know, and My wife knows it as a physician, you know, and she keeps her maiden name because she says, I don't remember a Dr. Markey graduating from my graduating medical school class, so she keeps her own maiden name as Dr. Blumenthal. But in your testimony, you spoke about how AI allows you to spend more time with patients by greatly reducing the administrative burden of charting. However, some of the healthcare organizations may look at AI as a means to just cut costs by cutting their workforce. So, Dr. Sale, can you speak to how the success of artificial intelligence depends on actual healthcare providers being involved, as you were saying in your conversation with Dr. Marshall?
Absolutely, thank you for that. You know, I would echo Senator Marshall's comments earlier, how this is a tool, right? It's much in line with the EMR. This is a chance for us to optimize our workflows, improve our efficiencies, add information, and perform tasks that historically take away from our time with our patients, and add value back to our encounters so we can work with our patients more closely, listen to our patients, and really develop a more beneficial relationship with our patients than we can get when we're typing in information into an EMR. So I think there is a tremendous opportunity, I think, to continue to utilize this as a tool. I think it's important to remind our clinicians that that is what it is and that you still have to play a role in this. Because what I fear sometimes is complacency or over-reliance on this tool, right? And so you think about instances where in an EMR we've copy-forwarded an error, right? And so how do we avoid that with this kind of a tool? Because I think AI has the potential to propagate errors.
So can I just, so how should a nurse view this? As a threat to her employment or as an augmentation of her ability to help with her patient care?
It's a great question. I would say if you were to ask my nurse, she would love to spend less time on the phone doing work that is beneath her level of licensure and doing menial tasks and chart review and chart things that could be done by AI, and rather spend time with the patient doing education and training. So I think most of our nursing staff and our clinicians would relish the opportunity to remove themselves from some of those administrative and documentation tasks that we've become overwhelmed with in our EMR world, and instead focus our time and efforts with our patients.
So you don't view it as a threat?
I don't really think it's going to replace clinician judgment or patient engagement. I think if anything, we have a nursing shortage, a physician shortage, an overall healthcare worker shortage that's been existing even pre-pandemic and just exacerbated by the pandemic. So I think that this is, if anything, helps us close some of the gaps that exist in our ability to take care of patients.
Okay, great, thank you. Any other questions? Good. Beautiful. So here's what we're going to do. Finish up 1 minute apiece for each one of you in reverse order of the original testimony. The 1 minute you want the subcommittee to remember as we're moving forward on legislation to deal with AI as it interacts with the healthcare system. We'll begin with you, Ms. Huberty. You have 1 minute.
Thank you so much. I think it's important to know that I have been here today to describe the actual patient harm that is in place due to this AI and sound the alarms for the points where the doctors cannot override the AI and it causes that harm, that patient harm. It has a ripple effect through the economy, not only for that person's medical bills, but also the facilities that can't keep up and that can't accept patients anymore either. I think, I'm here to say this is exactly what is happening, and we can use this as a model. What can we do with this information now so that it doesn't happen with other AI technology in the future?
Great. Dr. Mandel.
I'd like to re-emphasize the importance of measurement, the importance of making data available so that we have AI trained on the full diversity of the American population, and so that we can monitor AI and its impacts along with boosting tremendously the way we monitor drugs, devices, procedures, and that we actually create a more efficient healthcare system as a byproduct. That is one important focus within this domain.
Okay, great. And Dr. Inglesby.
Yeah, thank you, Senator. I think I'd just like to close by reemphasizing the enormous potential benefit of AI in healthcare, but to get the full benefit of AI in healthcare and in public health, we need to now, at the start of this huge change, to address the risks not only of privacy, bias, data integrity, and beyond, but also focus on the very high-end risks around AI and the biological sciences. I think a number of ideas and steps are already on the table, but Congress can go further with some immediate steps and with more information from the agencies. Thanks very much.
And Dr. Sale, you have the final word.
Thank you very much. First of all, this has been an honor and a pleasure to be here. I would say, while I acknowledge the large-scale and big-picture concerns around AI, I feel like there may be some small window opportunities for us to utilize this technology in ways that really help improve patient care, physician and practitioner well-being, and can really actually improve our outcomes in healthcare with mitigating that risk. I think that requires close collaboration with our physicians and our clinical workforce as we develop these tools and define their uses of application within healthcare. I think it encompasses mitigating risk with privacy and security of data, and I think ultimately with the goal in mind of improved patient care and avoiding physician and clinician replacement, but rather enhancement of the practice of medicine.
Beautiful. Thank you so much. And like Dr. Naismith, you have served the state of Kansas very well. So we thank you for your testimony, although the best basketball player in the world right now plays for the Denver Nuggets for Senator Hickenlooper's home team.
Potentially.
I think it's an evidence-based determination I'm making on that.
Artificial intelligence.
Until that young man from Webiana down in San Antonio, he might quickly change the algorithm.
So we thank everyone who participated today, especially our witnesses who traveled here from Massachusetts, Kansas, Wisconsin, and Maryland. Your perspectives are essential for ensuring that we guard against the harms of artificial intelligence. We need to put people over profit, prioritize worker voices, and keep focused on how to best treat patients. So I ask unanimous consent to enter into the record a statement from stakeholders outlining priorities for addressing AI in healthcare without objection. And for any senators who wish to ask additional questions of our witnesses for the record, they will be due in 10 days. November 22nd, 2023 at 5 p.m. We thank everyone, and with that, this hearing is adjourned. Thank you.